Well, welcome to our video history. And I'm about to have the honor of interviewing Dr. Anna Marie DAmico, who I have had the pleasure of knowing for, I guess, maybe 20 or 25 years now. So Anna Marie, welcome.
Thank you.
And let's start really with background. Let's start with where it all began, where you were born.
Oh, a little town outside of Philadelphia, Conshohocken. Nobody knows how to spell it, but it's 15 miles west of Philly, but about 1,500 light years away from Philly. So I'm a Philly gal.
Yeah. Did you grow up there?
Yep, I sure did. And then went to a college in Washington, D.C.
Which one?
Catholic University of America.
Okay.
And then came back to Philadelphia to go to medical school.
Well, what motivated you to get into medicine?
Well, you know, I thought about that a lot. I always liked science, but I always liked people. And I couldn't think of a better way of putting those two things together than to get into medicine. Actually, though, I do remember in high school being interested in becoming a nurse, because you have to remember how old I was, or how old I am, how many years ago that was what you did if you were a woman in those days, and you wanted to combine a little bit of science, a little bit of people hands-on. You became a nurse, which is a noble profession. But then at some point I started thinking, you know, I'm not limited. I could do something else if I chose. So I went to medical school.
Well, how was it being a medical student as a woman?
Actually, it wasn't too terribly different during most of medical school. Jefferson, my alma mater, was actually the last medical school in the country to accept women. So I think they kind of bent over backwards to try to accommodate taking women and making up for lost time. I frankly did not know that fact until about 5 years ago.
Oh, interesting.
So they kept that a big secret. It was not something they were terribly proud of. But there were a few little funny little quirky things, which looking back, at the time I accepted, but I don't think anybody would nowadays. For the most part, they tried to treat us with respect and as equals, for the most part, with some exceptions.
Well, you know, I know now that essentially half the medical students in this country are women.
Right.
And when I was in medical school, probably about 10% of my class in the early 70s were women. How many were in your, what percent of your school class was female?
We were 10%. The class was about 200, and there were 20 women. But at the time, this was late 60s, that was the highest percentage of women anywhere in a medical school in the U.S.
Amazing.
So again, Jefferson was trying to make up for lost time there.
Well, what stimulated you then to go into obstetrics and gynecology?
When you went to medical school, I should say, went because things have changed. You didn't have any clinical experience for the first 2 years. It wasn't until the third year where you had some clinical exposure, except you spent one night in labor and delivery during your freshman year. And at the time, I was going to be a trailblazer, and I was not going to do any kind of typical woman thing. I was going to be a general surgeon because I thought that was the most antithetic thing I could do. It was not a woman's thing. But at any rate, so here I am spending this one day and one evening, I should say, in labor and delivery. And at the time, natural childbirth was not a big popular thing. But this lady had a baby, and it was a natural birth, and the husband was extremely supportive. And I remember it was an Italian couple, and this may get off color. It was a breech birth and a little boy, and of course, being a breech birth, the father was very happy with his son.
You knew early on what it was.
Well, he's also very happy with the engorgement and so forth, very proud of his offspring. And the mother cried when the baby was born, and the father cried when the baby was born, and the obstetrician almost cried when the baby was born. I bawled my eyes out, and the decision was made.
Okay. Birth is a wonderful thing.
It is.
A beautiful, beautiful thing.
Sure is.
So did you stay there for residency, or did you go someplace else?
I went to Wilmington, Delaware, nearby, and had a very good clinical experience, lots of volume.
Is that Christiana?
Christiana. It's now, at the time it wasn't Christiana.
No.
Christiana hadn't been built at that time.
Oh, okay.
So it was the Wilmington General in those days. But we had a large volume of deliveries, 5,000 to 6,000 a year, so saw lots of pathology. And eternally grateful to have been there because I met my husband in Wilmington. And if I hadn't gone there, who knows what life would be like.
So when you finished your residency, where did obstetrics and gynecology take you?
I think like most people at the time, stay where you trained. There wasn't the great joining of practices. In those days, you hung your shingle out, you started from scratch and saw a patient your first day. You saw 2 patients your second day if you were lucky. So I stayed in Wilmington and built up my practice to, you know, a nice, successful little practice.
A solo practice?
Yes, on call, 24/7, 7 days a week. That was
And how
challenging.
many years did you practice solo?
It was about 10 years, and then took in one partner. And I must admit I gave up OB at about probably 15 years in. It's the thing that drives you, pulls you into the specialty, but in those days of being on call so much, it's the first thing you have to give up, I'm afraid, or at least we did in those days.
Did you stay in the same area there in Wilmington the whole time?
I did. I've been in Wilmington my whole life, yes, professionally.
Well, that's, and I think you're retired now, right? Or am
I volunteer, so I'm getting paid what I'm worth.
And where are you volunteering?
There's a clinic for uninsured women, or uninsured people in northern Wilmington, and I was the only gynecologist there for many years, doing all the GYN care.
Oh, I bet that's rewarding.
It was. You know, I got my hand shook at the end of the day from the patients, and that was more rewarding than anything I could think of in all the years before.
Well, that's great. I mean, if people really appreciate, and I think sometimes when they can't afford certain things, they appreciate them even more. Well, when did you get involved with the American College of Obstetricians and Gynecologists?
Well, you have to start counting backwards, 3-year terms, but I was very interested. This is all serendipitous, and I think of how networking, how that works out. But I was at it was an ACOG meeting, and we crashed a Georgetown. No, it wasn't an ACOG meeting. It was a Georgetown. My husband went to Georgetown, so we went to some Georgetown cocktail party. And Joe Riggs, who was the District 3 chair at the time, was a Georgetown graduate, was at the party, and you know, we just met one another and started chatting, and I mentioned how I was interested in getting involved in ACOG. It was kind of hard to break in. There weren't a lot of women in those kind of positions. And Joe created a post on the District Advisory Council for me. I was the liaison to the nurses.
Oh my goodness.
So he created that to get me going, and then from there I went into the elected positions in this section. But now I thank Joe Riggs to this day for kind of getting me in the back door.
So how many different positions have you held at ACOG?
Well, we started with the nurse liaison, which doesn't exist anymore.
I'm not sure it ever existed anywhere else. I think you may be the sole nurse liaison.
Wow, that's a unique honor to have. Then I was the section vice chair, and then the section chair, the section being Delaware, state of Delaware.
Right.
And then I became the district assistant secretary, and the district secretary, and the vice chair, and the chair, and the immediate past chair, and then I was an advisor for another 3 years. So I'll have to do the math, all those times 3.
Well, you know, it's interesting. One of the things we're focusing on today is leadership, and as more and more of our members are women, one of the issues that comes up is those are all 3-year stints, and there's at least 7 or 8 of them in there. So that's like 21, 24 years. Looking back, do you think that length of time at each level was right, or think if it had been shorter, it'd been better, or what do you think?
I think it was perfect, because I think the first year you really don't know what you're doing, you're learning, and the second year you're in full bloom, and in the third year you really can bring things to fruition. It was interesting, I had a conversation with someone today who I will remain nameless, but he's at a very high level at ACOG, and I asked what his intention was for beyond his position. And he said he's done because he's too young to go for the top positions in ACOG, because that's a full-time job. So by the time you become a district chair, which is a half-time job, you really have to be kind of at the end of your career, not over the hill, but not at 40 years of age, because you can't afford to go to half-time practice in your 40s. So I know I may be in the minority. I do not see a problem with that length of time, total commitment, or 3-year terms. I think
that's interesting. That's a very good perspective. Now you have established the Anna Marie DAmico lecture, which is part of our annual President's Program.
Yes.
Tell me how that became reality? What motivated you to do that?
Do you want the background dope, or do you want the motivation?
No, whatever you want to tell us. That's what we're just here to learn.
Well, I think you do know the story that there was an investment family member and asked for to borrow some money, which of course you never expect to see those things
Right.
back. And his small business did succeed quite well, and there was a great windfall. But at that particular time in my life, I had resigned from my hospital position. I was not happy with the way the management at that place was going. And I expected to find something else to do rather rapidly. And as it turns out, it did take me 18 months to find another satisfactory position. And this was in that 18 months when I was feeling very worthless. You know, we measure so much of ourselves by being Dr. whoever. You know, Dr. Hal, Dr. Anna Marie. Yeah. And so when this came up, I thought, I can feel worthwhile. So I got so much more out of that than ACOG ever did. It made me feel valuable again to the medical profession until I found a job.
How do you feel when you're sitting in the auditorium on Mondays and the opening ceremony and they announce the Anna Marie DAmico lecture?
Yeah, you get a little flutter. It's a little, you know,
goosebumps?
Yeah, it makes you feel good. You know, we're all a little bit of an ego person, and it's nice to have your ego stroked. And you guys do that.
You know, it's nice to see people who have the opportunity and then the motivation to give back, and it's really, really appreciated.
Well, I did put myself through college and medical school, so I think it's important to give back for other people. And, you know, ACOG needs this to keep the ACM going.
Well, we appreciate it. What would you say is the most enjoyable position, the most exciting position you've held at ACOG?
Oh, it has to be the district chair, being on the executive board, where you can really make decisions. You can really impact what is put out. You can impact the literature that's going to the public. You can impact the literature that's going for your fellows. And I think there were times when I was rather vociferous and I think made a positive impact on both women's health care and the doctors' well-being. So definitely being on the executive board where you really could do something.
Was there ever times that you were really pretty disappointed with what was going on at ACOG?
That's interesting. I hadn't thought about that.
I have to be careful asking you that question. I know I might get more of an answer than I'm anticipating.
I actually don't. I mean, I feel very positively about ACOG. I think they really get it. They really do. They try. They bend over backwards. They try to represent their members, because it is sort of a trade guild, but they also represent women. And sometimes the two are in conflict, and somehow they walk a good line in between. The only time I have any issue with ACOG is when I wanted to be CDC chair, and they didn't elect me. But that's my peers. That's not ACOG. It was their fault. Their mistake.
Well, you know, it's interesting. You and I have lived through, I think, some dramatic changes in medicine and some really dramatic changes in obstetrics and gynecology. How do you know, I'm sure you saw changes throughout your practice, but where do you see our specialty today? And then I'm going to follow up on that and ask you where you see it going down the next few years.
Well, I think that those two questions have to kind of come together. And so I thought about this for some time. I am a generalist. I was a generalist. I was very happy to be able to do everything for women that OBGYNs do. I mean, we did infertility surgery back then. There was no REI. We did cancer surgery. I did post-radiation hysterectomies. But I think the generalist doesn't get the same acknowledgement, respect. I'm afraid the generalist is going to disappear. I think the generalist may become simple deliveries done by midwives and other physician, I don't say physician assistants, but other non-physician providers. And all the cancer cases or adnexal mass cases, be they benign or malignant, are going to be in the hands of oncologists, and any bladder problems in urogyn, and what's the generalist going to be left to do? I mean, gosh, pap smears are only every 5 years now. So I do fear the loss of the generalist. Of course, I have the solution to that too, but nobody listens to me.
Well, I'm getting there. Where do you see the role for the obstetrician gynecologist in the primary care of women?
I think that has to be somewhat limited, because otherwise we're not respecting the family doc who spends 3 years in residency just learning that kind of stuff. So we'd have to have 3 years of that if we're going to be equivalent to the family doc. So I think very limited basic primary care, at least recognizing when someone needs to go elsewhere. You know, I don't want to be treating heart disease. I don't even particularly want to be treating hypertension. I think other people do it better.
Okay. Well, where do you see the solution of protecting the roles is what I call the specialists in obstetrics and gynecology? I'm trying to work on this word generalist versus the subspecialist in OBGYN. What would you propose we do to protect that role?
Oh, I have the solution.
I know you said you did.
And actually, you're correct. The generalist is a specialist. We are not family doctors. We are specialists. I think people need to all take 1 or 2 basic years of OBGYN training, and which, of course, everyone does take basic years now, but they take 4 years of basic training. Most people by the 2nd year know they're heading towards MFM or Gyn-Onc or something. I think there should be 2 years of generalism, and then you specialize in general OBGYN, just like the family doctor is someone who's residency trained as opposed to a GP. So you go on a different path. You go on the path of being a generalist, or you go on the path of being MFM. Once you decide after your 2nd year you're going MFM, you don't waste the clinical material doing hysterectomies. That's the other problem. There's not enough clinical material out there for people to be adequately trained. And the guy that's going into Gyn-Onc doesn't have to spend his or her time in labor and delivery, because that's not where he's going. And so everyone spends more or less 4 years. And there's not the lack of respect, and I don't mean respect, but lack of leveling of the field. So the generalist has trained as long as the MFM guy or the GYN-Onc guy. So he is at the same level and has the same importance in the sphere of care of women, OBGYN care for women. Anyway, and I think everybody will be happy with that too, because I don't think anyone wants to be training for 4 plus 3. Is it some of the subspecialties are 3?
Correct. They're all 3 now. And actually, GYN-Onc is looking, or has already started a 4th year.
Yeah.
So.
Who wants that? Because most of these guys and gals know much earlier than 4 years of OBGYN residency that they are going to go on that track. So.
Well, I think you make a good point, because the percent of people who are subspecializing has dramatically gone up.
Right.
But at the same time, 82% of our residents now are women, and their perspective of a full-time practice is a little different, because most of them have families. And you said you did OB for 15 years. They tend not to be doing it for quite that long. What can we do to help keep them involved, delivering babies for longer than 8, 10 years after residency?
I thought that was tracking or trending back because of the large groups that have sort of evolved as a necessity.
Well, maybe in some parts of the country, maybe in the Northeast, but generally we see about 1/3 stop obstetrics in about 10 years, actually.
Okay. Well, I think since it is not happening as much in the Northeast because of the large groups, that is the answer. It's the Generation Y, and they want personal time. I'm not blaming them. It's very important to have personal time. Quality of life is important.
When you're proposing the way we would look at residency training, it's sort of a 2-year core and then 3 years of something else.
Sure. That seems to be a win-win all around.
Yeah, I know there's been a lot of talk about that for a lot of years, and I don't know where all that will end up.
A lot of talk.
Yeah, that's probably true. In our career paths, there have been lots of interesting changes as to how we provided care. If you had to pick 2 things, technology really things, that changed women's health care in the 30 years or so that we practiced, what would you identify?
Well, I mean, the first one that came to mind is ultrasound. I didn't do ultrasound when I was a resident. We didn't own an ultrasound machine in the hospital. And the very first ultrasound I ordered in my life, obstetric ultrasound, I guess any ultrasound, was I was about 6 weeks into practice and inherited a patient whose uterus was not the right size for gestational age. So I ordered an ultrasound. It was a mole. And I remember getting the report saying, calling the radiologist and saying, well, how do you know? I was so unfamiliar with this test. Can I rely on this? It was so. Just think, if you hadn't had that ultrasound, what do? You wait until when? I can't imagine practicing OB-GYN without it, but yet I did trained without it. So ultrasound, of course, and of course it's become so much more sophisticated now.
And the resolution is just incredible.
Yeah, exactly.
Just unbelievable, yeah.
Baby's first baby picture is at 8
I know.
weeks of
You
age.
see everything.
Yeah, it's incredible.
The father doesn't have to wait for the breech birth to find out.
So that's, I mean, to look back and just amazed at that kind of stuff. Another one significant thing, it'd be hard to pin down one thing, because there's been advances in cancer therapy, but I can't pinpoint one that's as dramatic to me as the ultrasound. The other thing that I have to mention is the biggest change that I've observed is when I came into practice, it was all natural childbirth. I mean, that was all there was. And then I understand that maybe 5 to 10 years after I stopped OB, it's all epidural and, wake me when the hairdresser arrives. The whole Phyllis Diller type delivery.
Right.
And I think that has allowed for the group practice of obstetrics. When we were doing natural childbirth, our patients had a relationship with their doctor. You became the coach, whether you wanted to or not. They expected it from you, and that's what the role you had to fulfill. But once you're, having an epidural and having a more comfortable time during the labor process without losing safety, that you don't have that bond to that individual person, so you can accept the group practices, the large group practices.
It is interesting, and when you mentioned when you went through in medical school that it was all natural childbirth, I started to ask you if it was almost the old twilight sleep that people used to use.
I'm not that old.
That means I'm now older. That means I'm now older. So we don't have to ask about that one then. If you had the opportunity of advising our young physicians, and you may be doing this in some of the volunteer work that you're doing, what would you tell them about obstetrics and gynecology, or even a group of medical students? What would you tell them about our specialty?
The wonderful thing about our specialty is such a blend of so many things. So you have the wonder of obstetrics, and I don't mean to be, facetious about that, but it's a wonderful aspect of medicine that's unique. And you also have surgery. Which surgery is nice, it's fun, it's enjoyable, but you don't have to learn 150 different operations. Essentially, we do 5 operations, and you can be very good. You can become a good surgeon in those few areas you operate on, and that's a nice feeling too, to be a competent surgeon. And you do a little bit of primary care, whether you intend to or not. It happens.
Right.
So it's a nice blend of 3 very unique specialties.
And the group practice, I suspect, is making the call so much more tolerable than it used to be.
I think that's why, at least as you say in the Northeast, we're not seeing people quitting obstetrics quite as early.
Well, that's very good. If you wanted to tell me about the college, is there any particular areas that you think the college should be being more aggressive or looking to go into a new, different area?
Well, we'd have to talk about the Congress rather than the college. So
we can talk about either.
Okay.
Talk about either one. We'll just talk about ACOG, so we don't have to say whether the C is college or Congress.
Okay. I still think the fellows feel very troubled by the lack of tort reform. And I know I've been on the legislative committee, we've tried, but we're not going to get the big bang buck change. But if we get something, If we could change our gears instead of trying for the California type model of reform, the global one, get something through so they can see that, hey, maybe it's an inch, it's a step in the right direction. That would be, I think, appreciated by the fellows.
Well, I agree with you, but it's interesting. It seems like the successes we've had have all been at the state level,
yes,
and not at the federal level.
Well, a lot of our federal successes have been negative things that we've stopped awful things from getting passed.
Correct.
But the fellows don't see that.
Yeah.
And again, I know when I lobbied and worked on the committee, but they don't see that we don't have fetal pain, that we don't have some of these other, not so fun laws passed.
Well, one of the areas that we started into more broadly about 3 or 4 years ago was our international activities. Now, we had been involved in Central and South America for 15 or 20 years, but we're now really reaching out across the pond, they say, into Africa. Do you think that's something that we should be doing to help women's health worldwide?
Well, I mean, I think global health care is important. I got very involved with the Dominican Republic, which is now a section of District 3.
Right.
They had wanted to join for some time, and then things just stalled. And I went down to the Dominican Republic kind of on my own with ACOG's blessing with some of the ACOG district officers, and I kind of re-energized and got them to join. What we were doing beyond that, I don't know, but the maternal mortality rate, when you hear and read these awful things, these awful numbers, I mean, how can you not get involved? How can you not want to do something, not try to do something if you can?
And I agree. You have come, I'm sure, to lots of annual clinical meetings over the decades. We're in the process of looking at our annual clinical meeting to see if we can make it more energized. Any suggestions you would have for us as how we might improve our annual clinical meeting?
I think you've done a lot to energize it. The interactive stuff is what the young people seem to really like, and that makes it much more interesting. The hands-on and simulations and so forth, that's a big change. Otherwise, I like it.
It tends to be growing again, so it's getting bigger again, and we're really very, very pleased about that. Trying to find the right topics and the right cities to keep everybody really involved.
Las Vegas.
Okay.
That's one suggestion to improve it. Let's go to Vegas.
Well, it's interesting. There are groups of people who really want to go to Vegas, and there are groups of people who don't want to go to Vegas. Yeah. It's always hard to keep everybody pleased. How do you see? The district meetings are evolving too, and how do you see those changes going over the last 10 years or so?
Well, when I was district chair, one of the things I tried to do was combine the district meetings. You really can't hold a district meeting solo, with some exceptions. Armed Forces and some other districts are rather unique. Combining them, and I think that you asked about the ACM, having kind of a mini ACM or a macro ADM, East Coast, West Coast, or East Coast, West Coast, Central, in addition, I think is the way to go. Get some help from national so we can bring in better quality speakers than some district meetings are. Some are good, some are not as good. But yet let the districts still have some say and have their own personal, social interaction. Networking is very valuable. I mean, so much happens. If I hadn't gone to that cocktail party at Georgetown, I may never have gotten active in ACOG, so networking is valuable.
I think that's a great message. I mean, that's a message that everybody needs to hear. And these days, you can go online and you can get a lot of CME, and with maintenance of certification, you can get lots of CME, but you don't get those networking.
And it has a tremendous value.
If you were going to tell ACOG one thing, say, I really want ACOG, you're doing lots of things good, but I really want ACOG to take a hard look at one new area, what would you choose that new area to be?
A new area.
Not an old one, but a new one.
Oh, you're really challenging me. I'm not running for president,
But you could.
I don't have to have these hard questions. I wanted easy questions.
Well, you've been doing so well, though. It's like the board exam. The better you do, the more interesting the questions get.
Oh, golly gee. Well, I think we've done a good job in encouraging women in leadership positions. As you may or may not remember, that I am the only woman to chair District 3, first and only.
Right.
But more and more that's being encouraged. You almost can't help it with so many women now members. I mean, it's just going to happen by default. But I think ACOG actively encourages that. I think they didn't do such a good job before. I think that there was a certain bias against women. I shared with you that my big disappointment was when I did not get the CDC chair.
Right.
And some of my friends, and I not just colleagues, they were friends, and they're lifelong friends that I still see socially, share with me afterwards, they just didn't think that as a woman I could do the job as well as a guy. But I think that is changing at ACOG. And so I'll just say the one thing I think that ACOG maybe didn't do as well before, but I think they're correcting it. I think they're coming up.
Okay. Well, it's been a real pleasure, and you've certainly been a real force at ACOG and in District 3, and showing all the wonderful things that women OBGYNs could be real icebreakers for our specialty. So Anne Marie, thank you very much. This has been a great session and a great interview.
Thank you, Hal.